Okay. Now, Mark, are you going to have PowerPoint to show?
Uh, I no, I had that presentation, but not sure how to join this to link it.
You have it up on the desktop.
No, I can load it into the desktop.
Why don't you do that? And we'll do that right before we start.
You have your thing.
And then I'll show you how to share it.
You're gonna do this?
Yeah. Let's see if we can do this. Well, let's where's my IT help?
Oh, we got another person wanting to join us.
It's
Probably our warden.
Yes, it is Warden Williams.
Yeah.
So tell me when you're ready, Mark, and I'll tell you how to load it, how to put it on. And what we'll do is I'll go ahead and introduce you and let you introduce yourselves and let the warden introduce himself if he wants to. And then I'll give you instructions on how to share your screen, okay?
it's an idea. We're not there yet.
No, that's fine. One thing at a time.
I can just find it on my desk. Yeah, this is it. Of course, it should be bigger. It's a little bit small.
It might be big when they load it.
You can go to the slideshow mode.
Slideshow mode, okay.
But you might not want to do that yet. You might want to do that after you share it, okay?
Okay. 1 second, let
So
me go
tell me
back.
when you're ready to go to the slideshow mode and then we'll start.
How do we do
Oh God.
this?
He has it up on the screen.
1 second. Oh,
That's fine.
shoot. Okay.
Look. All right.
So what would you like?
Have it up. Now, can you click the Zoom camera on the bottom tray
Yeah.
and put yourself back in video so you can see us?
I think right here.
We'll do that 1 second.
Okay.
Nope. Where'd the video go?
It looks like you turned your video off.
That's amazing. How did I do that? Okay. Let's go back to
Bottom left, there should be a video camera that you click. Should have a line through it right now.
I'll go back to this. Click on him. So right there. Okay, there.
okay, video.
Okay. Now, here's what we're going to do. I'm going to go ahead and start, introduce you, and then we'll walk you through how to get your charts up. Okay, welcome. My name's Tom Stark. I coordinate the NAMI Santa Fe public information meeting, and we're very fortunate tonight to have with us representatives from the Santa Fe County Corrections Center. We have Melissa Oberg and Mark Boschelli, and they work with the health and the behavioral health programs at the corrections facility here in Santa Fe County. And the title of their talk is Integrated Medical and Behavioral Health Services to Inmates from Intake to Release and Reintegration Back into the Community. And so we're going to let our speakers introduce themselves, and then we're going to let them put up their presentation materials and walk us through their presentation. If you have questions, please use the chat function, And if we get questions on Facebook, Jessica will be monitoring those and she'll relay them as well. And then at the end of the presentation, we'll let anybody who wants to ask questions and address those questions then. So with that, Mr. Boschelli, Ms. Oberg, would you like to introduce yourselves and your topic?
Sure. So my name is Mark Boschelli. I'm the Behavioral Health Manager here at the Santa Fe County Adult Detention Facility here in Santa Fe, New Mexico. I oversee all the behavioral health programming as well as behavioral health services for the residents of our detention center. To my right is Melissa Oberg.
Hi, my name is Melissa Oberg. I'm the program manager here at Santa Fe County Detention Facility. I oversee our electronic monitoring. I oversee re-entry, our volunteer coordinator, and our teacher. And I've been in corrections for 23 years, 10 of it private and 13 of it here in Santa Fe County.
And I myself am somewhat new to corrections regarding being inside the facility. But I come from a background of around 35 years in the behavioral health field, primarily working with mentally ill and substance abusing individuals out in the community. 2 years ago, I was able to switch into a position here at the detention center, primarily because I was concerned about what do we do with individuals who have a mental illness and or primary substance abuse problem. What goes on for them in the facility? I previously would have clients go into the facility and then come out, and really they were never able to tell me what happened, if they had medications, if there was treatment, etc. So I was actually concerned about that and decided to see for myself as well as participate for myself. Prior to my position, I had been a consultant in the actual design up of this facility when it was built. So it was kind of interesting to step into the facility then as an employee of Santa Fe County, and then basically was impressed by what we're doing. And that's hopefully what we can convey in this presentation, because I don't believe that we're able to communicate well enough to the community of service what goes on for these individuals. It's not a black hole, it's quite the opposite. I have found it to be a very sophisticated system of care that helps individuals, but we do have some difficulties upon release, and that's really what we've been trying to improve. Interestingly, this facility has up to a capacity of around 550 inmates, but currently we're down to around 385 to 400 inmates. And one of my focuses when I was an outpatient provider was to somehow, how do we divert individuals away from the detention center who have a primary mental illness? Because around the country, you find out that detention centers have become the de facto substance abuse and mental health centers. And I was hoping that somehow we could decrease that amount of individuals coming in. And interestingly enough, when we talk about the COVID-19 pandemic, it has actually been the solution. And I say that in a way that you start to understand that we've decreased our population by up to 39% of these individuals who would usually come into this facility due to mental health issues and substance abuse issues. But around 39% of these individuals have been diverted out. In other words, it seems like law enforcement, as well as the probation officers and parole officers, have decided that instead of bringing them from the community due to a violation into the detention center, they've decided just to keep them at home or link them up to alternative services. This was one of our primary goals in the community, and inadvertently, we have achieved that goal. And we did not really understand why that happened until we started looking at the statistics. Across the board in the state of New Mexico, you are seeing around 20 to 30% decrease in detention center stays for individuals who are not violent, who haven't caused major crime, but usually was due to their mental illness situations as well as substance abuse. So as we start out this discussion, just be aware that some of this diversion has actually occurred due to a pandemic of all reasons. So actually we've solved some of this problem, but we're interested in conveying the information of how we do an integrated program. Here, behavioral health's primary goal is when someone comes into our facility, we want to make sure that there is not a completed suicide. The reason we focus on that right away is that within the first 24 hours, someone coming into this type of setting is usually, they're jarred due to coming from the community and then all of a sudden finding themselves in an incarcerated situation. So the first 24 hours have always been a concern. That's when people have usually still been under the influence of substances. In addition, if they have a mental health issue, they might have been off their medications for a long period of time prior to incarceration. That individual has been tried to be hospitalized, but that hospitalization did not occur for different reasons, maybe not meeting criteria to go into a hospital, or they've had some type of family conflict, and as a result, they've been arrested by the police and then they've been brought to this facility. So that first 24 hours is a concern. So what we actually have here from the integration from once the individual walks into our facility, there's a thorough intake that is completed by one of our RN nurses. The intake is accredited by the New Mexico Association of Counties. It covers basically all medical concerns as well as psychiatric and substance abuse concerns in history. Now that intake is a verbal intake. Sorry, we just have our fire alarm going off. That's a verbal intake as well as it's an observation intake by the nurse. So from the first onset, 24 hours a day, the nurse will basically look and observe if there's a trigger point. What I mean by that, if the person's not oriented well to time and place or who they are, or if they can't give us information of prior medications. So we're kind of asking that individual right away if they're on medications, primary medical care medications, or psychiatric medications, or if they've recently taken up substances. So that's a verbal interchange. It's around for 45 minutes. But before they even get in the door, due to the COVID-19 pandemic, they're also screened outside in the usually the sheriff's car or the police, Santa Fe Police Department's car for COVID responses regarding exposure, if they've recently had a COVID-19 test, as well as symptomology of active COVID-19. If they've shown symptomology, we've had to revise a lot of our pods here at the Santa Fe County Detention Center to be ready to be able to isolate those individuals. So our presentation was kind of designed prior to the COVID-19, so we'll go back into that. But after the nurse is looking at them, checking their temperatures, which happens for every individual who comes into our facility 24 hours a day, the nurse will give the clearance that the person can come into the door. If there's a behavioral health issue, what we mean by that, we will actually ask information from the law enforcement officer who has brought the individual in. Did anything happen in the car? Did anything happen on the scene that should be of some concern for us? A lot of times the police department or sheriff's department are really some of our first indicators of if there's a mental illness present. They might say a family member was concerned. The family member called the police department to come to that house to do a wellness check on that individual. So we'll right away try to get information from people who were involved in the situation prior to coming in. Then we'll actually ask the inmate who's coming in, the incarcerated individual. We'll ask them if they have a mental health background. Do they have medications that they're on? Do they have substances that they're on? You know, we try to do it in a very open and honest fashion. Around 50% of the time, we get very straightforward answers of prior medications. If we know about prior medications that they've indicated, we'll ask them to sign a release of information so that we can immediately contact that pharmacy to follow up to see if those medications are current. If they are current, that individual who might have mental health issues, right away we will start the inclusion of medications into that individual. But sometimes it takes a while to get that information back. So it can be up to 24 hours to get that person back on their psychiatric medications if they have a psychiatric illness. Similarly, with substances, sometimes we get a lot of conflicting substances that the individual is currently on. What we've been finding out is that we don't get individuals who are just on one substance, you know, just alcohol, or has a mental illness and just alcohol. We have pretty much 50% of our individuals walking in our gate here have really 2 or more substances laid on top of psychiatric medications. And those are not prescribed substances. So it really confounds the picture right away for that individual as we're trying to interview them. And remind you, you know, this is 24 hours a day, 7 days a week. So if there's a concern, right away the nurse will flag and make a referral to our behavioral health system. I myself, I'm covering the medical aspect in the area for psychiatric issues to do the pre-screening of the individuals who are in need of psychiatric medications. So we have a medical unit already set up here at the detention center. It's a 17-bed medical unit that's basically a medical and / psychiatric unit. So if someone is unstable, we're concerned about their well-being. We're concerned that they're not on their medications. We will make that referral and then place them into the medical unit and not clear them to the rest of the general population. One of the ways to think about how this is set up at the Santa Fe County Adult Detention Facility is think of a clover leaf. You have a stem, which is our main access point, and then you have 4 different units, or you can think of 4 different leaves. And those 4 different units have specific pods inside each one of those units. And one of those units is a female unit, and then we have 3 male units. So it's really a city within a detention center. And then at the bottom of the stem, in that kind of picture design, would be the medical unit. So the medical unit is separate from the general population units on purpose. The inmates would call it the kind of dull and boring unit because we don't have TVs or anything really recreation, things like that in the medical unit. However, our focus is on care and stabilization for those individuals so that we can move them to the general population, which is those 4 other units. So as someone comes through, we're also doing something else because of the nature of New Mexico. Is we recently got a grant from the Department of Health for an opiate overdose reduction program. And during that time, we're checking for signs of opiate overdose. So that's checking the blood pressure as well as the other vitals of that individual, because we want to curtail active overdose right there in the beginning. What we have found that over time, we've had people who have ingested opiates prior to being arrested and being transported into our facility. So we've had to intervene with Narcan to help bring them back from an opiate overdose. So we have all these things going on in our central intake area, which is in our booking area before they're even coming into the regular part of the facility. So medical is already in contact with every single individual coming in. And then if there's a referral, it goes right to behavioral health. And what that means is I go back and then I'll do a secondary interview for that individual. So you can see whether we're integrated right away. This is not a separate medical or behavioral health program. I remember my first day on the job when they offered me my position, they asked me where I wanted my office. And I came in the front door and it was nice and quiet and looked like a regular business suite up front. And of course, inside, I said, I want to be up front. But then I kind of realized with a clinical background that I should probably be back in medical. And so they escorted me back in medical, and it was loud, and there was a little bit of shouting and banging on the doors and smells that, were not the best. And I said, oh, I guess I should be back here. And as a result, we purposely, I'm based back there with the medical doctor so that we have daily communication within the same walls. So
Go ahead.
yeah, we just got word that the warden can't hear. We apologize. And our warden, by the way, is Derek Williams, who has been very supportive, as well as the Santa Fe County commissioners who have funded this program quite well. When we look at overall behavioral health issues, we're looking at around 15% of our population is currently a major mental illness for the males. Around 20% of the females have a current profound mental illness. But realistically, 85% of our population have substance abuse issues. Substance abuse is, I would say, dwarfs the just singular mental health issues here at this facility. As a result, we have a focused evidence-based program to work on substance abuse issues which support the stability of the mental health issues. So on staff, we have up to 6 licensed behavioral health counselors. In addition, we have a 40-hour prescribing certified nurse practitioner who specifically is set up for our psychiatric medications. What we do, and we're quite proud of what we're doing regarding not prescribing any addictive medications for these individuals. At times, they're not happy about that because they come in with a great deal of kind of prescribed medications that over time they've built up a tolerance. So we purposely don't have that on our formulary. As a result, we are trying to really move away from addictive medications for these individuals. So upon discharge, they are set up in a better situation. So since 2 years ago, we started the Matrix model, which is an evidence-based model for substance abuse treatment. We have set up 2 pods, one for males, one for females. Those pods are specifically programmed. In other words, they have a therapeutic community model that these individuals are able to work on their substance abuse issues as well as stabilize with their mental health issues. And that program runs for 30 days. We have pretty good outcomes data from that, and that's part of my conference presentation, which unfortunately, due to COVID-19, once again, got pushed back, and then it's now just an online conference with the National Commission on correctional mental health issues. But in our matrix model that we had started and been running for the last 2 years has been basically put on the side because we've had to make those pods open to intake from the individuals from the community. So we can do a 14-day isolated intake for both males and females, as well as if an individual is COVID positive, then we have a whole isolation pods. So it is kind of set us up to decrease our substance abuse programming. So that's an unfortunate part to it. But in that substance abuse program, we use a lot of the evidence-based programming, which basically uses cognitive behavioral therapies, as well as we teach yoga, as well as we teach other relaxation techniques, as well as we have our own medication-assisted treatment modality, which is a little bit different than the community's treatment modality. Our focus is on sobriety, So we are not currently using any type of Suboxone here. If someone comes in from the community with Suboxone, we do titrate them down and off of that. We offer naltrexone as an alternative medication-assisted treatment. What we have found during our matrix programming for these individuals who choose to go into this program is that trying to get someone sober from all their different levels of substances has been basically a huge challenge. So we have endorsed the idea of a sober model. In other words, no substances outside of our prescribed psychiatric medications are basically accepted into that program. Since that time, we have found a number of things that have occurred. When someone sobers up, they can start thinking. They're able to incorporate the material much better, actually try new techniques instead of using substances. Once again, this is an incarcerated type of situation. So, we look at it as a confined sobriety. It is caused by coming into the Matrix program, but once again, it's a voluntary program. Our outcomes have been quite good, quite frankly. Our recidivism rate of someone who comes back and reoffends and ends up at the detention center is pretty good. We've only have around a 3% recidivism rate for males coming back who have graduated from the Matrix program. The women's recidivism rate is around 2%. This is compared to 80% reoffense for people who don't go through this program. So we do think we have something here, but once again, this is not the end all. This is one of our programs intertwined into a full medical behavioral health program. So for the individuals with a primary psychiatric diagnosis, our goal is to stabilize that individual out, get them back on their medications. Our difficulty has been is that people don't stay at the detention center for a long period of time. The actual tenure here is 9 to 14 days. So a lot of times we have people who come in quickly and leave quicker than we can even get them back on their psychiatric medications. So if there's any caveat, I'd like to convey the information that, this is not a psychiatric hospital. This is not a substance abuse residential treatment facility. This is a jail. It has, those big, thick, clean, doors that make a lot of noise when they close. It is not really conducive to psychiatric stability. I have noticed that it takes twice as long for an individual who has a psychiatric crisis and comes into the detention center to stabilize out as compared to an inpatient hospitalization setting. A lot of that, it's not due to lack of care, lack of hospitality. It's because it's a jail. And I've just noticed that, you're not able to freely walk around. You don't get your own room. They're cells, they're like those old dorm rooms. And it's not conducive to really healthy rejuvenation. So if there's any thoughts of let's put someone in a jail and they can get all this great treatment, I would not push that. I wouldn't suppose that that's the way to go. In fact, my goal would be to divert as many people out of the detention center as possible. And usually the best diversion that I've seen is prior to coming into the detention center. So once again, the COVID-19 pandemic has actually achieved some of this goal of diverting individuals away and towards hospitalization. Once someone comes into the adjudicated system and ends up here at our detention center, the research would back this up, is usually their stay at a detention center is twice as long as someone who doesn't have a mental illness. And so it's really not the most conducive place for stability, even though we do try. We purposely have an IDT meeting every week. In fact, we just came out of our interdisciplinary team meeting. During that time, we have medical representatives, we have the psychiatric representative, we have the behavioral health staff, as well as security staff, where we can identify those individuals with a mental health issue, And then we talk about how they're reacting to their environment. And we're trying to figure out whether it's their primary mental health issue, their substance abuse issue, or there's just the idea that they don't want to be in jail. I personally would probably fall into that category at times, but you know, it's a more of a complicated picture. So that's why we have the different disciplines who purposely talk from their own perspective of how to work with that individual and make it safe for that individual. We will review in our interdisciplinary team meeting anyone who's possibly had a suicide attempt or has possibly used substances that might have infiltrated into this facility, because we're always trying to figure out who has substances on them, who's using substances while here, and our goal is to really decrease that, the means as well as the individual abusing those substances. So the interdisciplinary team meeting is part of the next step of our whole program of moving inmates from the intake to programming within. And once again, our primary programming is for males and females in the Matrix program. But then we have a whole new direction that we're going in addition. What we noticed that individuals who were filtrating through our facility, we would stabilize them out on their substance abuse issues or mental health issues, but then all of a sudden they would get released. And once again, the release is up to the judges, not to the detention center. We don't have any control over that. But what we would notice is upon release, they would really sometimes wouldn't make it all the way down Route 14 back into Santa Fe before they would be reoffending. We looked at that and we were kind of disturbed by that, because we thought, you know, once you're released, everything is, you know, nirvana and everyone's happy. But actually, that's not the case. A lot of times our individuals don't have a place to go back to. A lot of our individuals need to be linked into a substance abuse treatment program or a behavioral health program. And they basically fall off the face of the earth from stability that they've achieved here at the detention center to all of a sudden going back into the community, being very vulnerable to being preyed upon, being homeless, as well as not linked up to caregivers. So we've come up with the next phase of this integrated model, and that's what Melissa is really going to talk about.
Okay.
Before we turn it over to Melissa, there are a couple questions that have come in that I'd like to get to.
Okay.
One of them is just, you talked about people with psychiatric disorders and people with substance use disorders. What percentage are co-occurring and have both?
Yeah, we're looking at, well, overall of our population, I would say 85% of our individuals fall under the auspices of a behavioral health diagnosis. Of that 85%, well, of the total 100% population, I'd say 15% males have a primary severe mental illness diagnosis, as well as 20% of the overall population of females have a severe mental disorder, diagnosable disorder. But 85% of these individuals totally have both substance abuse and mental health issues. So it's a primary factor here.
You're saying 85% have both?
Yeah, yeah. And what I mean by that, there's lighter mental health issues such as the PTSD issues, anxiety disorders, depression.
So not necessarily SMI.
Yes, not necessarily severely mentally ill. Yes.
Okay. The other question that we got was, our members, very many of them are family members of people with serious mental illness. And what opportunity is there for family members, especially for, since you're an adult facility, you're dealing with adults, but to find out about the status of their adult brother, son, whatever, who gets incarcerated, who has a serious mental illness? What communication opportunities are there? And, you know, what communications opportunities are there when the individual's about to be released?
Okay, so I'll try to break that into two questions. Hopefully I'll answer them. You know, we are you know, guided by the HIPAA issues, but with family members, I'm willing to talk to family members, quite frankly. They can call my direct line because I do believe family members should be informed of whether their loved one is back on medications. Because once again, people get out of here. I usually on a regular basis talk to individuals who have guardians, treatment guardians. I will communicate to them directly through my phone line. I don't have any difficulty talking. I mean, I'll give as much information as I can, but I will, respect the individual because they are adults and they are usually covered by HIPAA. We will ask the individual, can I talk to a family member? Sometimes they might say no, but we'll still want to give out as much information as possible. My direct line, so you know it, is 428-3121, area code 505. Once again, it's area code 505-428-3121. If I'm not in my office, I will get back to that individual if they leave a message and try to convey as much information as I can. In my view, loved ones deserve to have some information, especially if they're concerned about, dangerous levels of that individual or against themselves or against family members, as well as to know that we tried to put them on medications and they refused, or some information that's pertinent to help everybody's case. The second part regarding release, quite frankly, that's not up to us. Sometimes we get informed 15 minutes before they're released that the judge has ordered their release. And we can't hold them any longer once a judge proclaims that they're released. But the reentry director here will be able to say on some of those individuals who've been court-ordered release to facilities, and she can go into detail that those we have a much better handle on because we have a approximate date, a time, a projection, and that has been much more faithful to helping us understand where they're going to go upon release. And the difficulties have been more along the lines of placement, getting them into a facility. So that has delayed their release. Hopefully.
No, that's helpful. Now, from what you said, I would imagine you would urge family members to, in some sense, get involved with the court process and that sort of thing to be able to, help them get the help they need, or it's not just the corrections facility that's the only one that's available to talk to.
Yeah, the difficulties are with the court systems. What I've seen is, we only have like this one blunt instrument, and that is declaring whether they're competent or incompetent to understand the charges against them. And unfortunately, I'm just going to speak honestly about this, that can postpone their release from detention center up to twice the amount of time that someone would usually get out for their slight offense. And what I mean by that is a lot of times, we look at someone who has a mental illness type of charge. In other words, disorderly conduct, aggravation against a family member, destruction of property. Those are usually associated with a severe mental illness. And, I would love that charges would get dropped, but that's not what happens. And they get asked to go to the forensic unit at the state hospital at New Mexico Behavioral Health Institute. But the timing of that can take up to 3 months. It's supposed to only take 30 days, but we've seen it placement to take up to 3 months to get treated and then brought back to stand those charges. But judges do appreciate any information from loved ones about how that individual was doing, whether they were battling their mental illness, whether they were being compliant with medications, and what they were seeing. So talking to the judge does help. But, unfortunately, we have only one tool, and ideally we should have more tools. That's why I push for diversion before they come into the detention center.
Okay, couple more questions real quick. Who's your current psychiatrist?
That is Rebecca Granger. She is a certified nurse practitioner in psychiatric medications. She's with us 40 hours a week, 3 full days, that's 4 10-hour days. I'm sorry, I apologize. 4 10-hour days. So she's on premise. During the COVID-19, we did do some more telepsyche, and that actually was accepted by the inmates. So we didn't really see any difference between face-to-face or telepsych. So, but we have 40 hours a week, which is pretty impressive, I gotta tell you.
Well, thank you. And then the last question was just, do you also, I know you mentioned the matrix model for substance use, but do you also bring mutual aid groups in, like 12-step, AA, NA, other organizations that send volunteers in to do meetings?
Quite frankly, yes. The only difficulty, once again, with our pandemic, we've had to move to Zoom for our AA and NA meetings. Those are the two 12-step programs we have found extremely helpful, as well as invited by the inmates. They've been doing pretty good with the Zoom meeting, AA as well as NA meetings. So we're going to continue that, because at this moment, no visitors are allowed or volunteers are allowed into our facility due to the COVID-19 restrictions. Over time, we hope to loosen that up, but you know.
Okay, I think we're ready to move over to Ms. Oberg. Ms. Oberg.
Hello. So as Mark was mentioning about our reentry pod, so the program focus is a 30-day integration of comprehensive services for the reduction of recidivism. And by doing this, we'll be able to keep the matrix and programs in one location. And the population that we want to focus on is our inmates that have been sentenced for good time, and those inmates sentenced to a program. We also, those inmates that graduate from the matrix unit will also go into this pod. And of course, volunteers who want to make a difference in their life and are ready to do so. The programs that we are going to focus on are going to be, of course, drug and alcohol, anger management, mental health issues, education. Do they have a GED? Do they want to, if they have a GED, do they want to continue college courses, which we're linked up with the Santa Fe Community College to do. And of course, our volunteers and life skills. And these life skills is we want to make sure that they know how to obtain a ID. We want to have, when they get released, we want to be sure that they have a resume going out the door. And the staff that are going to participate in this reentry is going to be our mental health, our teacher, our community reentry specialists, our reentry specialists, and of course, community volunteers and our classification managers. And so the main thing is, from day one, once they get released, we want to be sure that they know what to do, they know where to get help, and transportation, living, where they, you know. And we do have a booklet that, I don't know, can you see me?
Yes.
So we have this booklet, it's called Pre-Release Handbook. And in this booklet, we already use this right now in our facility. This is gonna tell them preparing for a job, applying for a job. We're also going to do mock interviews with these individuals. So when they know what to do, what to expect when they go interview for a job. And they'll have a little card that will have like the emergency contacts and so forth. And they also know that they can contact our reentry specialists at any time. If they do come to a block where they don't know what to do, they pick up the phone and call us, and we have helped many individuals. I don't know what else. And we do have a resource book that we do give them that has all the resources here in the community here in Santa Fe. But that's our main goal is incentive is to connect them with resources in the community after release. That's all really.
Excellent. Thank you very much.
You're welcome. Was I too fast?
So now what I'd like to do is throw it open to see if there are any additional questions that the people watching might have.
You get to sit with me, Melissa.
Okay, I'll wear my mask.
We are being masked again.
Well, it's, we totally understand. Most of us are from our homes, so we have a little more flexibility than you do. But I guess a question I would have for the two of you, what is the one thing that the community could do working together with corrections to help achieve better outcomes for people with psychiatric disorders?
Well, that's a good question. We like the idea of a partnership with the community, both with law enforcement as well as with agencies such as NAMI. I do have pretty good experience previously, running the psychiatric crisis team here in town, understanding what families are up against when someone stops taking their medications and possibly gets aggressive or threatening and attempting to put the person into the hospital, and then that person not getting accepted into the hospital. If anything, I would like a better avenue to get the person into the psychiatric hospital and help from the community members to making that happen. Even here, when I see somebody in the medical unit and they're going to be discharged or released very quickly, I will write a certificate for evaluation if I feel that they are in danger to themselves or others due to their mental illness. I will author a certificate of evaluation, and our correctional staff will actually drive somebody over to Christus St. Vincent's, wait with them in the emergency room for them to be evaluated. So we're doing as much as we can. The difficulty we've had is I don't have much success of getting that person into the psychiatric floor for stabilization. Believe it or not, that concerns us. Even though they're no longer in our custody, we feel, we're ethically bound that individual needs continued treatment. And, we're afraid for their own safety as well as family member safety that they're coming back into. So if it was somehow that there was an easier conduit towards that, because that is not a smooth access point. The second part is, I know we've talked about and in our community about having assisted outpatient treatment, and I'm really not sure how that would work. I do believe that we could probably work with the community members, the community providers, so that I could get some of these individuals with a profound mental illness integrated into the assertive community treatment teams in our community. We had, under the direction from the Santa Fe County, we were starting to have community interdisciplinary team meetings about specific individuals who were frequently the emergency rooms as well as the detention center, and trying to get them assigned to the assertive community treatment team. Unfortunately, with the COVID-19, that's put on the wayside. But I do believe that would be the way to do it, because we would welcome a community provider to come in for a meet and greet of their new client. We would facilitate that. We would help with their clearances. We would guide them so they could be a face-to-face meeting, so that upon release that they would have a known entity to go back into work to follow up with their behavioral health treatment. That's when we're talking about a whole continuum of care service delivery. I would like help from the community regarding formalizing that. And then lastly, what we noticed is if the community could monitor how they're prescribing some of their prescriptions. We notice a great deal of individuals who have access to profound amounts of Suboxone. And what I mean by that is these are not just prescribed Suboxones, or if they are prescribed, they're clearly not taking it as prescribed. And then they're confiscating them with contraband into our facility. And other members are trying to use and abuse the substance while they're in this facility. But you know, the idea is that that would be much more regulated and, you know, just made sure that, you know, prescribers were really watching those individuals who they're giving that life-saving treatment to. But, you know, unfortunately, we see a lot of individuals who are not prescribed Suboxone who are coming in with Suboxone. So that tells me that there's a lot of that in the community. So that's just what we noticed, and we would like help from the community regarding
that. Excellent. Melissa, anything from your end?
No, Mark said it all.
Okay.
I have a question.
Sure.
Hey, Mark.
Shoot,
Mark,
Yes.
this is Betty.
Yes.
Did I hear you just say that you would be in favor of assisted outpatient treatment?
Well, you know, if it wasn't just a large adjudicated issue, from what I've read about the assisted outpatient treatment, it's really just a black robe effect. In other words, there's nothing else around it.
Yeah.
Yeah, and really the guts of an assisted outpatient treatment program is really an assertive community treatment team wrapped around the individual.
And that's what they're doing down in Las Cruces. They've got it tied in with their ACT program.
Yeah, it has to be tied in because the black robe is only going to be the black robe effect to kind of give the presence of authority that you need to stay on your medications, but it's actually the provider that provides all the services.
Right.
That would be helpful because I mean I see people who come in here who, you know, we're worried about their lives. They're going back into a homeless situation, and we know they're not going to follow up with their medications. You know, that's upsetting to us, quite frankly. And trying to get them linked to assertive community treatment is challenging, and then challenged on top of that is our COVID-19 pandemic.
Mm-hmm.
And as a result, even, you know, when I interview the law enforcement officers, they're like, well, at least the jail is a safe place. And I'm like, no, it's a jail.
Yeah.
So,
but even treatment guardians, I don't know how successful you are with, you know, that's kind of a black robe sort of deal too, because, you know, there's no consequences to, you know, going off your medication, except your treatment guardian could, you know, get involved and try to get you back on them, but a court order.
So I've seen treatment guardianships work quite well in a confined setting. So whether they're in the hospital or a detention center, treatment guardians are at their best. In other words, we can impose medications on someone as long as we have a treatment guardian's okay.
Yeah.
And we will. We actually are skilled in doing that. We have no hesitation about it. Similar to a hospital, which won't have any hesitation. Where the treatment guardianship becomes much more looser and diluted is on the outpatient basis.
Yeah. In fact, you can't even know sometimes if somebody has a medication guardian, a treatment guardian.
That's right. That's, if anything, what we're doing pretty good here. If anything, I want to applaud our medical staff is, you know, there's some good institutional memory of individuals who come in numerous times, and they'll flag right away saying this is a behavioral health issue for this individual. And I think they had a treatment guardian. And what we've started over the last 2 years is if we have a treatment guardian, we'll try to contact them and then get their paperwork faxed to us so we can put it right into their clinical record. So we'll know right away that they have a treatment guardian. But you're right, sometimes it takes some sleuthing to figure out that there's a treatment guardian involved. But it helps us when there is one.
The beauty of AOT is that, you know, I'm sure you see the recidivism in the jail. They should see it in the hospital, but we've never been able to get the hospital to agree to partner, you know, with the district court and put a program together.
Yeah.
I would think that you see recidivism in the jail, which would be a great place to have an AOT program.
Well, I'm not sure how that would look. I mean, once again, once they're here, we'll implement stuff on them, and once again, we try to partner up with our clients, first asking if they take medications. And actually, 80% of the time, we get individuals voluntarily taking their medications. It's surprising. It's actually equitable to an inpatient setting of the compliance rate. The extra 20%, those are the individuals that everybody in the community would like to get them medicated. And they're much more of a challenge for us, as well as for us to release them right back in the community. I'm like, oh my gosh, this person should be on meds.
Yeah.
Mark, let me ask a different question. You made reference to the fact that obviously things are being done differently now with COVID. But my question is, which of those things are going to be things that you would continue after COVID that are just sort of like improvements that are making everything work better?
Yeah, thanks, Tom. That's an excellent question, because I've been kind of stepping back and looking at our changes in an objective fashion. I like that we're doing such intense screening of individuals prior to them walking in the door. Even though it's under the rubric of COVID-19 screening, it's actually, a lot of times we're able to figure out behavioral health issues right there before they walk in the door. Because the communication has been really strong with the police departments and the sheriff's departments. So I'd like to continue that. And we're set up to continue that. The screening being really a strong presence right the first minute that they come in. Because our view is if we can figure out all the indicators right there at that spot, everything else runs much more smoother towards community reentry. Second of all, we like to keep the diversion of those individuals out of the detention center. If there's somehow to, knocking off 40% of these individuals from coming in here, clearly indicates that they did not need to be in the detention center. So is there somehow that we can continue to hold on to those gains? Because those individuals, that the probation department, as well as the sheriffs, as well as the police department decided, let's not put charges against them, but let's put them right into treatment. Hopefully after COVID-19, entrance into treatment would be quicker. That would be a positive change to help that diversion situation. But if anything, I want to really emphasize that, if we can stop an individual with a major mental illness, and the reason that they're even showing up at our gates is due to behaviors associated with non-compliance of psychiatric medications, the detention center is not the place for them to be. Any alternative is better. And I work here. I'm just being really honest, just out of compassion, any place would be better. That would be help these individuals. Once they're in the adjudicated system, it will grind people up, and it takes a long time, eats a lot of our resources, and in the long run, a lot of times the person's charges are dropped. So, I don't believe that's really where we want to put our resources.
How about in psychiatric telemedicine? Would you continue that?
Yes, we'd probably continue that. We see both. We like the inmates like to have the presence of the individual to talk to. However, we like to have the access 24 hours a day with our psychiatric prescriber via telehealth. The warden, as well as Santa Fe County commissioners, they have invested heavily to make sure that there's a strong psychiatric medication component and access here, that with a consistent provider, it's actually such an improvement to have one provider who starts to get to know the individuals over time, even with repetitive times. Much easier to set up rapport, much easier to get them on their medications again. It is something that we will continue. I'm very pleased that the warden decided to expand out from 20 hours to 40 hours for the presence of the prescriber. That's really made a great difference towards stability for our individuals who are here.
Excellent. Excellent. Are there any other questions from the people we have. Jess, did you raise your hand? Do you have something from Facebook?
No, we had a thank you from Craig O'Hare. He said it was a really informative session.
Excellent. Any other questions, issues from our listeners? If not, Mark and Melissa, I'd like to thank you for an outstanding presentation with a lot of new information that I certainly had heard before, and I think many of our other members hadn't either. As I said, we will distribute this information via the recording that we did. And, you know, thank you very much. I think this, for the presentation, for the program that you're running at the facility. And I couldn't agree more with your statement that we really need to integrate between the community and the facility and the hospital and the courts so that everybody is focused on trying to find a path for people to be successful and sort of giving them an integrated, holistic support instead of handing them from one organization to the next, as we sometimes have done in the past. So thank you. Before we go, I don't know, Warden Williams, would you like to make any closing comments? Obviously, all the great things we've heard tonight have been set in motion by your leadership, and we'd be glad to take a few moments and hear anything you would like to add. He may not have audio, I realize that.
Yeah, I don't think he could hear.
Okay.
He was having,
Well,
well, he's there. He was having trouble. He could see, but he can't hear.
well, I hope, well, one, we will have this on the YouTube channel, but could you please convey to him our appreciation for your being able to give this presentation and for all that you do?
We sure will.
Thank you. Betty, is there anything you'd like to add as president of NAMI before we close? You're muted, Betty.
Am I now? I'm unmuted.
You're not muted.
I just
Yeah,
want
we can hear
to
you now.
thank you both for taking time tonight. I know you have a busy day and it's a long day, and appreciate you doing this for our community and everything that you guys are doing too. That's great. Thank you.
Thanks for having us.
Thank you, everybody, and
Bye.
we'll see you in a month. Thanks.
Okay.
Bye.
Bye.